Okay, recording in progress. Okay, so for any of you who have not attended before, I'm Maria Markowitz. I'm from the Georgia Cancer Center, and I'm part of the hub team of our TeleDerm project. Dr. Doug Patton and I will be serving as co-facilitators of today's TeleECHO session. I'd like to ask everyone to put their screens on gallery view so you can see, we can all see each other when we are not sharing our screens. So if we can have the next slide. I want to remind everyone about our wonderful website at Augusta University. It's the Teledermatology Serving Georgia website. The link is on this slide, and there is a lot of great information on the pages of this website. So first of all, there are a link to all the recordings of the past 30 plus TeleECHO sessions that we've done. We have some training videos that are available for you to watch at any time at your own convenience. And some of which that if you enter the correct way, you can get CME credit for watching these training videos. So there's a lot of really good information out there, and I encourage you all to check it out. So I would like to welcome all of our participants today. So some of you I know are PCPs at various healthcare centers around Georgia. Some are specifically from the East Georgia healthcare centers, and many of those from EGHC are participating in the clinical part, the phase 2 clinical part of our TeleDerm project. So I welcome you all today. We have residents and some faculty from the Family and Community Medicine residency program here at MCG, and the family medicine residents are also participating in the clinical part of our program. And then we have folks from our MCG's Department of Dermatology, that Dr. Harold Rabinovitz, Dr. Kendall Buchanan, Dr. Loretta Davis. They're all on board. We might have even a derm resident. There might be MCG medical students who are here with us today. And then we have, of course, members of the Georgia Cancer Center TeleDerm team who are attending. Brenda is handling the controls by herself today. With Kenza Mamouni is home on extended vacation, back in visiting family in France. So it's Brenda and I running the show today from our own offices rather than from our hub site. And then previous participants from whom might be from across the globe might be here, and we welcome you. And then anyone who is attending our TeleECHO TeleDerm program for the very first time, we welcome you and hope you all will return. So I mentioned earlier to please write in the chat, everyone sign in with your name, what your affiliation is, what clinic you're from, what your role is, and most importantly, your email address. We need this all for our record keeping. So to review what our agenda for today, well, we've done our introduction. And then we will have the didactic part of our program, which will be presented by Dr. Vinnie Seiberling, who is Associate Professor of Dermatology at Tufts University School of Medicine in Boston. And this is the third presentation by Dr. Seiberling that we've had, and we are very grateful for her presenting these lectures. She received her MD degree from Penn State College of Medicine. She trained at Mass General Hospital in Boston, did a residency in dermatology at University of California in San Francisco. And then she was the dermatology division director for the Maine Medical Center, and that's Maine as in the state of Maine. And she was medical director for the Maine Medical Partners Skin Oncology Clinic. She has a special interest in non-invasive tools for the detection of skin cancer, such as dermoscopy. And she's developed multiple dermoscopy curricula and served on the American Academy of Dermatology Basic Dermatology Curriculum Work Group, which aimed to add dermoscopy to the standard medical student education program. She has worked passionately to improve access to dermatology care in rural settings, both through Project ECHO education and through teledermoscopy with e-consults. She firmly believes that all patients deserve high-quality dermatologic care, regardless of their geographic location, and this just meshes beautifully with our teledermatology serving Georgia program. As I mentioned, this is the third of her TeleECHO presentations, and we were fortunate to have Dr. Seiberling visit us earlier this month, well, actually last month, I guess, in November, here in Georgia, and to consult with our clinical project. She met with the family medicine residents here in Augusta at MCG. And then she traveled to a number of the East Georgia healthcare clinics and worked with the PCPs there. And it was a great visit. We hope she'll come back again. And we're really grateful to her for working with us and sharing her energy and passion. And so speaking of passion for rural access to care, I will now introduce Dr. Doug Patton, who will take over today's session, coming straight from his car, although it's not moving, so we're okay. Dr. Patton is the Dean of the Southwest Georgia Regional Campus for the Medical College of Georgia and has spent most of his career as a rural physician. So Doug, take it away.
Thank you very much, Rhea. It's good to be here again, and I'm tickled to death to let Dr. Seiberling know that we're freezing to death down here. I think it's 56 degrees. So we'll have to have you come back sometime to enjoy some of our winter. So we will start like we normally do with a run through of some of the basic slides. And as you know, this is our routine. We'll do this, but I'll make it quick. The goal is to improve knowledge through telemedicine, and that's teledermoscopy and teledermatology at the local level. Dr. Seiberling's presence, physical presence, and actually visit has been an added boost to our efforts by actually giving some hands-on teaching. We appreciate that. Next slide, please. So these sessions are recorded, as we discussed earlier, and by participating in the sessions, you're consenting to be recorded. These recordings are valuable for many reasons, including the ability for us to have all of these sessions archived and available for re-review at your pleasure at any time. Because this is not a consultative session, we ask that you please don't mention any PHI in the discussions. This is education only. There will be information in the final slide and also in the chat about continuing education credits and how to receive credit for this participation. You can always raise questions and email them, or it's easier actually just to put questions or concerns, even if it's technology concerns. Please put those in the chat today. We do share this data notification because everything from registration all the way through tracking continuing education credits, we use this data not only to help you get your credits, but also to help us with tracking the success of the programs, and also how to improve the programs as we go forward. Next slide. So again, general Zoom reminders: mute if you're not speaking, unmute when you do need to speak. The chat is our best way for us to get to realize that you have a question. You can also raise your electronic hand. We'll be monitoring for both of those signs. And once we get into kind of an open question and answer session, you can just feel free to open your mic and speak up. Please leave your cameras on if possible. And when we're not sharing slides, use of the gallery view is helpful. It is nice to be able to put faces and names together, so please do that if possible. And again, if there are technology issues, I encourage you to use the chat so that we can monitor those concerns. Next slide, please. So again, it's my privilege to introduce Dr. Vinnie Seiverling as our featured speaker today. And she's going to talk to us about dispelling the myth of skin biopsies. And she's going to include some case presentations at the end of this, following the didactics portion. We will ask her to stop sharing when we're doing open discussion, unless there's a need for us to look back at the images, but that way we can see each other as we have question and answer and discussion time. So thank you, Dr. Seiverling. I'm going to turn it over to you.
Wonderful. Thank you. I'm going to start from the top. So thank you all. It's wonderful to see so many of the friendly faces and people that I met during my time in Georgia. Today, I'm going to focus on skin cancer, not just detection, but how do we biopsy a potential skin cancer? No new disclosures for me. The overall goals of this presentation are to review the most common types of skin biopsies. Those are shave, also called a tangential or scoop biopsy, also referred to as a saucerization. So shave, punch, excisional, and incisional will all be covered today. We're also going to start by taking a close look at the indications for why should we do a skin biopsy at all. And then we'll address some of those long-standing myths in medical education that we really need to call awareness to, because unfortunately, some of this misleading information has been perpetuated for years, and we want to make sure that we're approaching biopsies, particularly for melanocytic growths, appropriately. If you have any residuals from Thanksgiving, my kids personally had a very difficult time getting up today and getting going. So if there's one slide you remember from this talk, it's this slide. You feel free to take a screenshot of it. This slide summarizes the most important aspects if you're doing a biopsy of a potential melanoma. You want to try to achieve as much of obtaining that growth as possible. We want to get breadth and depth. And anytime you're doing a skin biopsy, you want to take a picture of the site, ideally clinically and dermoscopically, so that you can make sure that you're learning from the case and have made sure that you have secured an image of the location if a future procedure needs to be done. Okay, with that summary, let's take a deeper dive. When we are approaching skin biopsies, we want to ask ourselves, what are we trying to accomplish? If it is a skin growth, oftentimes there is diagnostic uncertainty, meaning we don't know whether it's benign or malignant. Is it infectious or inflammatory for a rash? If there's diagnostic uncertainty, then we want to do a biopsy to narrow our differential diagnosis. Most of the time, when we're doing a biopsy for a potential skin cancer, we use the code neoplasm uncertain skin because it really is the most accurate description of what we're putting in before we have the gold standard of the histology. When we're doing a rash, we often use a diagnosis like a pruritic dermatitis or other inflammatory disease without specification. For instance, in this annular eruption on the upper right of the screen, the differential diagnosis is pretty broad. And it isn't without a biopsy that we can confirm that this is indeed subacute cutaneous lupus erythematosus. Other indications for a skin biopsy are when we don't know whether the etiology is infectious. For instance, the bottom right image is actually cutaneous leishmaniasis. It was thought to be eroded and excoriated atopic dermatitis, but after biopsies were performed from the edge, we were able to get the correct diagnosis. And lastly, sometimes we know that something isn't likely to be malignant, but it's bothersome or irritating to the patient, and therefore removal is still appropriate. In all of these scenarios, a skin biopsy was performed. Before we start doing a skin biopsy, we ask ourselves, what's the goal of the biopsy? Am I trying to, if it's a growth, remove the growth entirely? And if so, what margin should I be taking? Or if it's a rash, we want to ask ourselves, where's the action? Is this a scaly epidermal process, or is it more indurated and possibly granulomatous? And I need to be getting into the dermis to get to the area of active inflammation. Other things you always want to keep in mind are the size of the growth. If it's very small, like 2 or 3 millimeters, maybe it can be comprehensively removed with a punch biopsy. But if something is 4 or 5 centimeters in size, it isn't going to be able to be removed entirely, typically with the initial skin biopsy. Another thing to keep in mind is the location on the body. Anytime we do a skin biopsy, there's a risk of a scar. And so we want to choose wisely, especially if it's a rash that's occurring not just on the face, but also on the torso. We likely want to do the biopsy on an area where a scar would not be as significant. Anytime we're approaching a biopsy, we want to reflect on what is our pre-biopsy suspicion. If it's, for instance, for a squamous cell carcinoma, well, those are processes that emanate from the epidermis, the top layer of the skin, and therefore they usually stick up or they're more exophytic. Whereas if we're worried about something deeper down, something indurated or infiltrative, then we know that our biopsy needs to get down into the dermis. When we're biopsying for skin cancer, it really helps to look at something with your dermatoscope first because it can help us categorize something as melanocytic, meaning possibly a melanoma, versus keratinocytic, like a squamous cell carcinoma or a basal cell carcinoma. Now, all three types of skin cancer can be successfully biopsied using a scoop or saucerization technique because that allows us to go under the epidermis and get the bulk of the tissue, whether it's basal cell, squamous cell, or melanoma. When you look at your choices for a skin biopsy, the most commonly performed biopsies are shave, which is also done as a scoop or saucerization. These are just variations of each other, or a punch biopsy. Excisional and incisional are not done as commonly, especially not as commonly in the primary care setting. Let's start with the workhorse of skin biopsies, the shave biopsy. Of all the biopsies I do, shave biopsies account for at least 90% of these. These are ideal choices for things that stick out. Those things that are exophytic and raised are easy to remove using a scalpel or a curved blade. I personally use a dermablade. There are many different variations of this. The reason the dermablade is so helpful is that you can achieve breadth and depth. If you angle the blade quite down, you can get a lot of depth. So it's important that you practice your depth because if you're too shallow, you can also just transect the epidermis, which won't give the pathologist any additional information other than there might be some scale or keratinocytes on the surface. So the beautiful thing about shave or tangential biopsies is that you can guide the depth and you can go very superficial or deep depending on what your goal is. The other thing is most of these can be done quickly. They don't require any sterile technique. This is a clean procedure, not a sterile procedure. And you don't have to do stitches, and usually hemostasis is very quick with aluminum chloride or, for instance, silver nitrate. Most of the time, this is the choice that we go with if we're suspicious of a basal cell, a squamous cell, or something that's just bothersome to the patient, like an irritated skin tag or an irritated intradermal nevus. This is what the setup for a skin biopsy, shave biopsy looks like. So just want to pause and let you take a close look at all the tools. It can seem a little overwhelming at first, but let's go around and look at what we really need. The first thing we must have is we must have anesthesia. And in my practice, we use buffered lidocaine, which is not ubiquitously available. The nice thing about buffering it with sodium bicarb is it hurts less when the lidocaine is injected. However, most sites don't have buffered lidocaine, and that's perfectly fine. You want to use 1% lidocaine with epinephrine. The reason to use the epinephrine is it gives you a hemostasis component. We usually draw it up with a 16 or 18 gauge needle and inject it with a 30 gauge half-inch needle. I know many of you at the East Georgia sites are working on getting all the tools needed. I encourage you to try to get at least 27, if not 30 gauge inch needles or 30 gauge needles, because they hurt so much less when you're injecting your lidocaine. The other tools that are imperative, we want to make sure that we have something like forceps, especially tooth forceps, to be able to pick up the edge of the specimen and then use your derma blade to go underneath. After you've performed that, you want to put your specimen in that formalin cup and then achieve your hemostasis, which can typically be done with aluminum chloride. Because this is a clean technique, the only thing you need to do prepare for it is an alcohol swab. And lastly, we put a little bit of Vaseline or petrolatum jelly on the bandage, and that's the end of the procedure. So that's a shave or tangential biopsy and can be done usually very quickly, less than 5 minutes. To be honest, the setup is what takes longer than the procedure. I want to pause and make sure that if you have questions about any of these tools, go ahead, start putting that in the chat. We can address those at the end after we talked about punch biopsies as well. So punch biopsies are different. Punch biopsies allow for obtaining tissue from the dermis and even the fat. The beautiful thing about a punch biopsy is it gives you full thickness epidermis, dermal, and into the fat information. If you do a shave biopsy, for instance, of a rash, and you don't get into the dermis, you might not get a reliable diagnosis. The majority of punch biopsies that I perform are 4 or 6 millimeter punch biopsies. I'd encourage you to avoid 2 or 3 millimeter punch biopsies. And the reason for that is that about a 0.5 millimeter of skin, or even up to 1 millimeter of skin, is lost during tissue processing. So if you do a very small punch biopsy, like a 2 or 3 millimeter punch biopsy, then the pathologist is only receiving a very tiny specimen, and that's at a higher risk then of sampling error. So if you're going to do a punch biopsy, I recommend 4, 5, or 6 millimeter punch biopsy. And when you do your punch biopsy, you want to go to the hub, meaning you want to push all the way down, typically in a twisting fashion, to allow for the curved scalpel blade to go all the way into the dermis and at the level of the fat. Now, because we do go deeper, we then need to close the defect. If you are going to close something, though, that's ulcerated, it can be very difficult, and you may need to use just gel foam or some packing material. When you're choosing the type of biopsy, you also want to cater it for the location. Here is the shin of a 12-year-old child who has cutaneous leishmaniasis, and we had to do 2 punch biopsies, one for PCR that went to the CDC in Atlanta, and the other for histology to help confirm that this was an infectious, not an inflammatory process. In these situations, if you're doing 2 punch biopsies next to each other, one for culture or one for an infectious process and one for H&E, which is hematoxylin and eosinophil, H&E, then you don't need to use different tools. You can use the same tool for both biopsies. All right, this is the setup for a punch. It's very similar to a shave biopsy, with the exception that we now need to be able to have our punch tool instead of our curved scalpel, the dermal blade. We use a punch. We also need to be able to snip the base of the specimen, which is why we need scissors. And then we need to be able to close the defect. And that is why we have fluoroproline, we have a needle driver, as well as forceps. Once the specimen is obtained, it goes in the formalin and is sent off to pathology in the same manner as the shave biopsy. Now, I suspect many of you have heard that if you're doing a biopsy for a potential melanoma, you should do a punch. And I need to dispel that myth, because the reality is punch biopsies allow for sampling only of a small area of the skin. There are many perils, if you will, of the punch for potential melanoma. If you do a 4 mm punch biopsy and something is 8 to 10 millimeters in breadth, you might miss the melanoma entirely. Another issue is punch biopsies only go so far down into the dermis or to the superficial areas of the fat. And so you might miss the depth, the true depth. And that matters because the true depth is the most important prognostic information for a potential melanoma, and that is the depth on the initial biopsy. So better than doing punch biopsies of potential melanomas, especially potential melanomas that have a breadth of greater than 6 to 8 millimeters, we recommend a scoop or saucerization, or perhaps an excisional biopsy, which we'll get to in a moment. Scoop or saucerization are variations of a shave, but a shave means that you're going along the epidermis, the top. Whereas a scoop, you're going under the epidermis to try to achieve breadth and depth. Now, the recommended biopsy margin for a potential melanoma is 1 to 2 millimeters at the edge, and you want to get down and into the dermis. At first glance, this might look like you're taking a spoonful of skin. It looks like a really large amount, but the reality is anything thicker than a dime in depth allows you to go deeper than a millimeter in depth, which will help you make the important next decision as to what type of wide local excision or other management information the patient needs for that melanoma. So most of the time, if I'm worried about a melanoma, I do a scoop or saucerization biopsy, which is what we did for this case. Now, those of you in Georgia, I shared this case with you because it's one of my most favorite teaching cases. This is a 63-year-old man who was referred from the primary care setting for a potential seborrheic keratosis. And when we look at his abdomen, we can see that this is a clinical outlier. It's also macular, meaning it's flat. Most seborrheic keratoses are raised and scaly, and typically have multiple other ones in the same area. Clinically, it's multiple colors, irregularly shaped, and dermoscopically, it is not a slam dunk benign growth. Instead, it has a wildly disorganized appearance and an atypical pigment network. This is a very nice example of a melanoma. Melanoma often occurs on the torso of men. It's more common on the legs of women. When we see a growth like this, we want to be able to do a biopsy at that time. This is disorganized, and most skin cancers are disorganized. They are disorganized because they have many different melanoma structures under dermoscopy. This one has a blue-white veil, which is a worrisome feature for an invasion, has been linked to deeper Breslow thicknesses of melanomas. It also has shiny white structures and what's called a negative network. So how do we do this biopsy? Well, we first of all take photographs. We take clinical and dermoscopic up close, far away. We mark out our 1 to 2 millimeter margin. These are the hands of my physician assistant, Amanda. She did this biopsy. She's prepared with the anesthesia is starting to work. We know that we need to leave that anesthesia in there for a good 10 minutes to take advantage of the epinephrine component. We do know that lidocaine acts immediately, but the epi takes a little bit of time. You know you're starting to get some of the epi benefits when you see that blanching, that whitening of the area around the growth. After it's been anesthetized, then the dermablade is used, and we can actually remove an entire growth this wide by not squeezing too tight. We just allow it to have its full breadth, and we take a scoop or saucerization and confirm that this was indeed a melanoma. 1.1 millimeters with some features like ulceration. Now, if you're unsure if you went deep enough, one of the things you can do is you can pause partway through a biopsy and you can reflect the skin while it's still attached. If grossly you see any pigmentation or you don't think you went deep enough, you can go back to the beginning of the edge of the growth and go under it and scoop the whole thing a little bit deeper. That is one way that you can really ensure that you're down to these little tips or tendrils of fat, which tell you that you're under the deeper part of the dermis. Lastly, you can perform an excisional or an incisional biopsy if you're worried about skin cancer. The caution I'll give you is that these are much trickier to perform. And the reason for that is they need to be done under sterile technique, and you have to decide kind of ahead of time, what am I trying to do and what will my margin be? Usually, a margin is dictated based on the skin biopsy results, meaning if it's a squamous cell carcinoma, we often take a 4 to 5 millimeter margin. If it's a melanoma, the margin is dictated by the initial pathology. So if you embark on an initial excisional biopsy, it's really hard to know what the margin should be. The other difficult thing is that these require a lot of tools. Excisions require that you have a full sterile tray available because you are going to have to close not only the epidermal level, but deeper down as well. So I very rarely perform excisional biopsies. I know that Dr. Rabinovitz and some of my colleagues in dermatology feel very comfortable doing these as the initial step, but I would say that if you're in primary care, this is probably not the best first step. Usually shave or punch biopsies are much preferred techniques for potential skin cancer. If you are going to do excisional biopsies, you anesthetize them the same way, and then you have to use your scalpel and go all the way down to the fat, typically in an elliptical fashion, and then close it primarily with vertical buried vertical mattress stitches. Typically, that's how we close the deep space, and interrupted or running stitches on the top. Now, excisional biopsies also carry a higher infection risk than other types because we are going much deeper, and these defects do tend to be larger. If you're embarking on skin biopsies, whether it's punch or excisional, you always want to consider your hemostasis. Hemostasis can be obtained in multiple ways. Classic, very, very affordable hemostasis is when you leave your epinephrine in there for a good bit, 10 to 15 minutes, and then you hold pressure after the procedure. If a patient is not on a blood thinner, this is often enough. But sometimes we also want to have aluminum chloride available. Aluminum chloride is very cost effective. We usually put it in a sterile urine cup with cotton tip applicators and apply it to the biopsy site immediately after the procedure. One of the advantages is this does not lead to dyspigmentation or that black eschar that we see when we use silver nitrate. However, a word of caution, if you are having trouble obtaining hemostasis and you've been using a good bit of aluminum chloride, you need to wait till it dries if you're going to then use any electrocautery, because aluminum chloride is technically flammable. Lastly, if you want to use gel foam, it is fantastic, and there's nice literature supporting this because you pack it into the hole, and it has a lower risk of having a needle stick because you don't need to do stitches. But one of the problems with gel foam is these packages of 24 sponges are quite expensive. If you're going to be performing biopsies on patients on blood thinners or very vascular growths like this pyogenic granuloma, then you want to have electrocautery or even thermocautery available. I know that some of you, I think Lynn and Wadley has these nice handheld Bovie disposable units. They are wonderful because you can use them. They get nice red and hot, and you can use them right on the biopsy site. The disadvantage is they're rather expensive and they're single use. Another mode is a hyfricator. Hyfricators are really wonderful because you can use them over and over. You just replace the tip. Okay. Lastly, incisional biopsies. There is sometimes a rule for not removing the growth entirely. For instance, this is a 5 centimeter in size acral amelanotic melanoma. And while we try to get breadth and depth and take as much of the tumor off as possible, if something is 5 centimeters in size, we cannot do that at their initial visit. So instead, we did a 2 incisional, meaning we cut into the growth to obtain a sample so that we can at least get a tissue diagnosis. One word of caution, we don't do this if it's quite small. For instance, if something is 6 millimeters, we don't want to cut into it. We can then just remove it entirely with our scoop or saucerization technique. Okay. With that, we've hit on the vast majority of the myths for skin cancer detection. I wrote this article a few years ago with some primary care colleagues, and I think we've kind of debunked many of these. Number one being the punch biopsy is always preferred for suspected melanoma. That is not true. In fact, that is not the preferred modality the vast majority of the time. A second myth is that wide excisional biopsy is needed for a suspected melanoma. The only biopsy margin you need for a suspected melanoma is a 1 to 2 millimeter margin. It is a wide margin that is used for the subsequent wide local excision. Another myth that I often hear in primary care and sometimes from the residents that I train is that if you do a partial biopsy, can't that spread the cancer? Not typically for skin cancer, because we have what are called tumor infiltrating lymphocytes that go into the area and often after the biopsy actually help clean up some of that skin cancer. And in fact, the risk of spreading is almost none. And we've talked now about the deep shave saucerization. If you don't think you went deep enough, you can actually go back and take more. You just want to alert your pathologist that there's either a kind of split specimen or a second specimen in that jar. And epinephrine can be safely used on digits, on the nose, on the ears, on genital skin. You just want to use it in a very small quantity. And sometimes it's actually very helpful, even on these areas, to reduce the risk of bleeding. All right, so here is the summary slide one more time. And I want to pause. We've had our first snow here. We're expecting more. I do have cases, but I'm sure that there are some questions.
Thank you, Dr. Cyberling. I was just looking at the chat and I didn't see any. Um, maybe not posted just yet. While we're waiting though, it seems to me that one of the most useful approaches to this, if you're concerned about how to biopsy, where to biopsy, and things like that, would that not be a great opportunity for a teleconsult to share the images and things like that? And then to say, here's my skill set. I can do these types of biopsies. Are these appropriate?
Yeah, absolutely. So that's one thing that Dr. Buchanan and I are both used to doing. So if we see something and we think it's a basal cell, then we will often say, perform a tangential shave biopsy. And we're in the process of getting the East Georgia sites set up, at least 5 of them, to be able to do that. We recognize not all primary care sites and not all primary care practitioners feel comfortable doing that, but Kendall, you feel comfortable guiding and saying if if you have that skill set, then you can suggest a shave versus a punch. Is that true?
Yeah, absolutely. And even more, if that's the kind of information that, you're hoping that I provide from the consult, then, or if you're unavailable to do biopsies at all, that's the type of information that's very valuable when the consult is placed, because then it helps me tailor that response to figure out exactly what you guys need.
Thank you.
We have a few cases. If we have time, Dr. Patton, I can just it'll reinforce some of the biopsy decision making if we want to do a few.
Absolutely. We've got a little time and I don't see any other questions other than a request for the PowerPoint. Of course, the whole thing is archived. The whole presentation is archived on our website if we need that. So go ahead and show us.
All right. So our next our case is a 33-year-old woman. She has multiple sclerosis. She started a medication called natalizumab. That's a potent immunosuppressor that crosses the blood-brain barrier and has been very effective for treatment recalcitrant multiple sclerosis. However, it's also been linked to many cases of melanoma. And unfortunately, 6 weeks after she started this medication, the congenital melanocytic nevus on her legs started to change. Now, congenital melanocytic nevi are present since birth. So it's important to pay attention to things that are congenital because things like seborrheic keratoses aren't congenital. They arise much later in life. So when this started to change, it took on new colors and it got larger. And this is what we saw under dermoscopy. So for those, I know Mitchell's on and a bunch of the people at MCG and in East Georgia, we started to talk about the triage amalgamated dermoscopic algorithm. We started to look at if something has a slam dunk appearance of a benign growth, for instance, an angioma, dermatofibroma, seborrheic keratosis, we don't need to be too worried. So for those of you who've had a little bit of TDA training, and I see Dr. Sheldon on there. We passed out the cards. Look, they're holding the cards. I love it. Thank you, Lynn. So do you think this is a slam dunk benign? No, I see Lynn shaking her head. Lynn, I love that you're on because you're going to get those biopsy skills going really beautifully so that you could do cases like this right there in Wadley. All right, so this is not a slam dunk benign. Instead, under polarized light, we see many different colors. We see what are called shiny white lines, and we can really only see those under polarized light. That's the first light that comes on when we turn on our dermatoscope. Okay, so then we ask ourselves, well, is it organized or disorganized? And I think we would have all said, yeah, that's pretty disorganized. And now we have to decide on the type of biopsy. So what kind of biopsy do we want to do for this disorganized growth that we're worried about skin cancer and most likely worried about melanoma?
Shave.
Yeah, shave, right? But we got to make sure we get under it, right? So we don't want to just take the top. So we mark out that 1 to 2 millimeter margin and then we go under it. So this is more of a scoop variation of a shave. A traditional shave will kind of go right flush with the surface, like for an exophytic. So this is that scoop tangential biopsy where we're getting under it. And what we can see here is there's no pigment left at the base. We have gone below the level of the epidermis into the dermis. That's what the white is. And in fact, there's little fat tendrils coming up. So we know we don't need to go a whole lot further than that. And this is the advantage of using a dermablade. We can remove the entire thing and then give our specimen to the pathologist in its entirety. One thing I want to mention is we don't want to do curettes of growth and send them for pathology because that kind of crushes and there's a lot of disruption to the epidermis then, and our pathologists have a really hard time interpreting that. So this is the specimen. It goes to pathology. That was a melanoma. She subsequently, by the general surgeon, then had a wide local excision that was much longer. Let's see, not much bleeding. How did you close it? You don't have to close it. That's a great question, Dr. Sheldon. You don't have to close it because this is just a shave biopsy. We put Vaseline on it and we put a bandage on it. And a week later, she had the definitive excision. So the advantage of shaves and small punches, but mostly of shaves, is you don't have to close it. She's going to then have a wide excision that ended up being 7 centimeters long, and that was closed with stitches. Great question. All right, so that was a melanoma, and unfortunately, there are many cases of melanoma in the setting of natalizumab. All right, maybe we'll do one more. This is a 12-year-old boy who had a worsening rash after a trial of 2.5% hydrocortisone. It did not improve. In fact, his mother said it actually got worse after they used the hydrocortisone. So many of you that I got to meet with, you saw how I work through my differential diagnosis based on the morphology. So I'm curious if anybody wants to either describe what they see or start to put in a differential. This is his clavicle and the chest area. Ah, I see somebody said round and scaly. Beautiful. So annular, round, ring-like, right? We definitely have scale. And the primary morphology here is either a macula scale, or sometimes use the term patch, but it's not a pustule or a vesicle. Plaques are by definition greater than 5 millimeters and raised, but most of these are scaly patches with that scale all around the edge. The other thing that's really striking is that some of them have central clearing, and some of them are a little more targetoid. And they got worse with steroids. So does anybody want to start to put in their differential diagnosis? And the dermatologist can certainly weigh in. Yes, I love it. Fungal. Okay. I will
I would
add
also think about pityriasis rosea.
Amazing. Pityriasis rosea, right? So that's these annular rings, sometimes with a big herald patch. Anytime I see something targetoid, I think of something called erythema multiforme. I think of cutaneous lupus, which can be annular, psoriasis, nummular dermatitis. These can all be annular. So you just hit on the big top areas, which is this inflammatory versus infectious? Or sometimes it's both. Annular things, erythema multiforme, pityriasis rosea, granuloma annulare, these are all inflammatory skin diseases, whereas tinea is the classic one where we see a fungal or ringworm causing annular ring-like areas. Sometimes we're able to do what's called a KOH. That's where we scrape the top of the skin. We look at it under the microscope in real time, and we can see the hyphal or fungal elements. The reality is that isn't available at most primary care sites, and it wasn't available in this case. So the nurse practitioner that I was working with wanted to get a diagnosis, and she did a biopsy. So where do you think she should do the biopsy? And by the way, he has this on his legs too. Yeah, abdomen's a great idea, right? Anywhere other than like the area on the clavicle or the face, we try to pick areas where if they have a small scar, it won't be immediately noticeable. In his case, he actually had it on his legs as well. And this is our nurse practitioner, Kay. She marked out the area. And the reason she marked the edge is that that is the area of active inflammation. You want to make sure you're biopsying where you're going to get the most information. So she did a 4 millimeter punch biopsy of the advancing edge, including an area with scale, and that was able to secure the diagnosis of tinea corporis. Tinea corporis is a medical term for a ringworm. And we all recognize not actually a worm, it's a fungal dermatophyte infection. And the really nice thing is that our pathologists can stain it and see those fungal elements so that we have a definitive diagnosis of tinea, which allows for a change in the management. Go ahead. Did someone have a comment? All right. So tinea is best treated with terbinafine, which is what this child was treated with. Topical terbinafine is fine if it's a very localized fungal infection, but if it's widespread like this child had, then an oral agent for 2 weeks is best. Other types of fungus like yeast or candida, which tend to be more beefy red, sometimes with pustules, those are better treated with azole antifungals. And so it's really helpful if you can try to narrow down, is it a dermatophyte, dry and scaly, versus a candida infection. All right. Concern for immuno. That's Kyle asked a really good question. That's a fantastic question. So it wasn't worried about immunosuppression because the other tidbit of history we were able to get is that he just started wrestling. And so he started a contact wrestling, and then unfortunately we saw several of his teammates over the next few weeks. So if he had failure to thrive or was very malnourished, then that we might worry about immunosuppression. But in his case, he had a good reason for having tinea. All right, so here are our take homes, and I'm sure we're supposed to wrap up. Peripheral scale central clearing, be on alert for a fungal infection. If things worsen with your steroids, then you've got to revisit your diagnosis. If you're going to do a biopsy of a rash, look for that active edge of infection or inflammation or the area that's indurated, because that's going to give you the most helpful information. And if it's a pink, scaly, annular eruption with central clearing, use terbinafine. It's preferred over the azoles, which are better for those candida infections. And I think I'm just going to save these. Those of you in East Georgia, remember that if you see something that looks like actinic keratosis, we saw some of those on our site visits. Many of you, especially there in Swainsboro, have access to these fun cryotherapy handheld, which really allow you to deliver cryotherapy at your clinical practice. So with that, I will take any questions. And if you did miss the last one where we talked about psoriasis, I believe it's recorded, but also the National Psoriasis Foundation is supporting another presentation on that next week if you want to hear it in real time.
Thank you very much, Dr. Seiberling. I don't see any other questions or anything. I wonder if Dr. Buchanan, if you had any last thoughts to share before we turn it back over to Rhea.
No, I think one question I often get from the family medicine residents is, or a comment, I guess, is like how quickly and small a lot of the biopsies are that we do. I mean, mostly from where I'm at, it's usually because most of the time I'm ruling out basal cell carcinoma, squamous cell carcinoma. So in those cases, you don't always need that deep saucerization, and you can take very superficial biopsies that Dr. Seiberling was describing. So it can be a quick process, and the more comfortable you get, the easier it will be. And so it's not like this huge daunting task that you're faced with. So it does get easier the more that you practice.
That's great advice, and I just want to thank everyone on here, including Dr. Davis, for joining us as well, and Dr. Rabinovitz. We didn't have much chance for lots of comments from everyone, but we're at time. So thanks everyone for participating. I'm going to turn it back over to Rhea to close us out.
Okay, well, what a great presentation, and I am really thrilled at the comments that we had, especially those from the folks in East Georgia who Vinny was working with few weeks ago. And so I think we've just got really great responses and interactions here, and really meeting the mission of Project ECHO and so forth. So thank you to Dr. Seiberling for the great presentation. Thank you to everyone who wrote things in the chat and responded. And if you did not, if you came in late and you haven't identified yourself in the chat, please put your name, your affiliation, and your email into the chat for us. There are a number of people who look to have signed on with one person's name. I assume that they were sharing the link. So if you can, please put your own name into the chat. So let's see. If you are interested in obtaining CME, the code number is here, 22787, and you text that to the number. Remember that you must be registered with the MCG CME office to obtain credit, and if you haven't done that or you need more information, you can contact Brenda or contact teledermatology at augusta.edu. So our next session is going to be January 12th. That will be the second Monday of the month. We figured the first Monday right after holiday breaks was probably not the best time to be holding TeleECHO. So we'll be on January 12th, and we do not yet know who will be speaking or what the topic will be. So we will let you know when we have that all figured out. So I think we can just wanting to wish everyone happy holidays, whatever holiday you participate in, and we'll see you in
Dr.
2020.
Margaret, Dr.
Yes.
Margaret. Hi, Dr. Sheldon here. Some of the EGHC champions, we're going to try to meet with Dr. Serverling virtually with this link. And I don't think we told you that. So is there, hopefully, we were planning hopefully to meet with her virtually just briefly afterwards to discuss some of the things that she talked about when she met with us.
Oh, so you want to stay on? Is
that
With
okay
Dr.
with you?
Serverling. Is that something we can do?
Yeah, that is. What we do is we'll